Kia ora tatou. Today we're going to think about the lung, and we're going to start with lung tumours. As with previous lectures, the stuff that you should already know because you have covered it in ELM too. So in particular, you covered these concepts of lung cancer. So what we're going to do is we're going to briefly review these, and then we're going to go on to a few new ideas. Okay, what do we need to know? So these are the lung things overall that you need to go and learn. They're in the curriculum map. This, again, I'm going to remind you, is the absolute baseline of what you need to know. You will need more than this to be a really effective doctor, but this is the minimum of things that you should know. Okay, let's think about bronchogenic carcinoma. So you would have learnt in year 2 that in lung cancer, there is a metaplasia, dysplasia, carcinoma in situ sequence, a bit like in the bowel, starting with tobacco carcinogens undergoing, for example, squamous metaplasia through dysplasia carcinoma in situ to lung cancer. There is another pathway which doesn't involve metaplasia and leads to adenocarcinoma. So here we have the atypical alveolar hyperplasia, then some pre-malignant in situ change, leading to adenocarcinoma. Small cell carcinoma, which makes up 15% of all the tumors, probably directly arises from stem cells. So here we have another basic idea that lung cancer is divided into non-small cell and small cell carcinoma. And the non-small cell carcinoma includes adenocarcinoma, squamous cell carcinoma, and large cell carcinoma, which is really very undifferentiated. And with new molecular markers and immunohistochemistry, we're being able to reduce the size of this group and assign it to either adenocarcinoma or squamous cell carcinoma. I'm sure you remember the key words for squamous cell carcinoma. So it's a central carcinoma arising from the metaplasia, and it shows intercellular bridges and keratin, and often presents with a cough or infection, whereas adenocarcinoma arising from the pre-malignant adenomas is a peripheral type cancer most often, and it is often associated with a central scar on radiology. Looking at the histology of these other types, of course, adenocarcinoma often has glands in it, and like most adenocarcinomas, can secrete mucus. Small cell carcinoma is also more central, hilar location, and is widely disseminated at diagnosis. So this means that while adenocarcinoma and squamous cell carcinoma can be resected, then small cell lung cancer, because it's already spread, is always treated by chemotherapy and can't be resected. Okay, some other things that you covered previously. Lung cancer local effects. So remember, cancer can have local effects and distant effects. So some of the local effects in lung cancer are really important because it can directly invade the nerve plexus that is present in the brachial area, the superior part of the lungs, okay? And therefore cause things like diaphragmatic paralysis, hoarse voice through recurrent laryngeal paralysis. There's this thing called the Pancoast tumor, which is a tumor that invades through the top of the lung. And of course, if it invades the cervical sympathetic chain, you get Horner syndrome. And then lung cancer is also famous for its paraneoplastic syndromes. This is where it releases hormones and causes abnormal hormonal action at a distance. In squamous cell carcinoma, it's parathyroid hormone related protein and causes hypercalcemia, but small cell carcinoma is well known for releasing Cushing's, like an causing Cushing syndrome and antidiuretic hormone release, and so causing syndromes associated with those endocrine hormones. And then, of course, all cancers, but particularly lung cancers, can have non-specific changes at a distance as paraneoplastic syndromes, such as neuropathy and dermatomyositis. Okay, so previously mentioned, and we'll mention these a bit more, were other tumors in the lung. Carcinoid tumors, which are part of the neuroendocrine spectrum of tumors, arise in the bronchi. You were told they were benign. They're not necessarily benign. I would say that they are mostly very low grade, and then you can get high grade ones that can metastasize and kill people. And then here we've got, of course, all the usual metastatic carcinoma in the lung. So that is a brief review of what you have previously learned. Let's have a look at a couple of MCQs. Okay, so try and answer these yourselves. Just pause the video now, pause it, and then I'll tell you the answer. Okay, so which of these is true? Do 75% of patients have a smoking history with lung adenocarcinoma? And the answer is yes. So while lung adenocarcinoma is the most common kind of carcinoma in people who do not smoke, more people who smoke get it. They're associated with paraneoplastic syndromes. No, adenocarcinoma is not. That's squamous and small cell. They arise in the hilum. No, they're in the periphery. It's squamous and small cell in the hilum. And histologically, they contain keratin pearls or whorls. No, that's squamous cell carcinoma. Okay, let's think about what's true in small cell carcinoma of the lung. Can surgical resection lead to cure in a number of patients? No, these are all treated by chemotherapy. They are all systemic by the time they're discovered. They're treated by chemotherapy, yes. They're the commonest kind of lung cancer. No, in fact, adenocarcinoma is the commonest kind of lung cancer. And they arise from carcinoma in situ? No, they arise from a stem cell. Okay, so let's have a look at some hopefully new things. All right, so here we have the rate for bronchogenic carcinoma. Let's have a look at it for a moment. Let's have a look in females. You can see that the rates in both Maori and non-Maori females have not fallen with time. And the rates in Maori females are much higher than in non-Maori females. You can see that in men, there's been a steady decrease in incidence, but that's been paralleled, Maori and non-Maori, and still Maori people have a much higher incidence of lung cancer. All right, in fact, they have a 3 to 4 times incidence and a 3 to 4 times mortality. Maori people are more likely to be diagnosed at a younger age. The answer to why is in all your public health studies. I'm sure you've covered tobacco smoking in public health. Late presentation. So you are able to answer this question why. What I really want to move on to is what the patients see when they get diagnosed with lung cancer. So when they get diagnosed with lung cancer, they want to find out more about it, and they go to the Lung Foundation, and there's a list of questions that they should ask their doctors, and this is one of them. Can we make arrangements to have my tumor tested using comprehensive genomic testing to inform my treatment? Okay, the answer is slightly complicated. If they have small cell carcinoma, the answer is there are no genomic testing that will help your treatment, and therefore it is not tested. If it is a non-small cell carcinoma, then we will automatically send them for genomic testing. So what happens? What happens is a tissue sample is needed. So they need a biopsy of the tumor, and this is sent for conventional histology. And then we put it through next generation sequencing to look at what genes are activated. This bit here, fluorescence in situ, no, that is out of date now. We don't do that. We just go straight to histology to tell us what type it is, because the type is related to the prognosis. Micropapillary carcinomas, for example, do much worse than acinar type carcinomas. And then next-gen sequencing. This is under development, but is not yet available. So hopefully people will be able to have this test without having a lung biopsy in the future. So why do we do the next generation sequencing? That's because there are treatable mutations in lung carcinoma, particularly adenocarcinoma. And these are the main mutations, right? EGFR and ALK. So let's have a think about this. So this is a standard molecular activation pathway, and it starts here with EGFR, okay? And then it activates this pathway through the mTOR path and the MAPK path, leading to increased survival and proliferation of cancer cells. So if we can switch it off by blocking this receptor, then of course this pathway will be switched off for a while until the cancer cells mutate and work around it. These are only two of the many mutations that are present in lung cancer. There are many, okay? So what do we actually test for? What we test for is ones that have drugs that we can treat for, okay? So these are the MedSafe registered medicines in black here. So we test for EGFR because these medicines can be used to treat it. We test for ALK because these medicines can be used to treat it. We test for NTRK1 because, again, it's got a medicine we can treat it. And similarly, ROS1 because they have medicines that are funded here. It's we could test for everything, but that would be a waste of money if we can't have the medicines here in New Zealand. Okay, so what happens is it goes into the next gen sequencer, we see which mutations it has, and then the oncologists can choose the drugs. Curiously, the ethnic background of the patient is related to the number of mutations that, the type of mutation that's present in the lung cancer. We don't know why. Okay. And here is a handy table because you're always being asked this in MCQ questions of what kind of table, what kind of tumor gives rise to what kind of drug. But I'm so mixed up here. What kind of tumor gives rise to what kind of perineoplastic syndrome? You'll learn more about lung cancer on your Kura Cloud. And the exercise I particularly want you to do is to look at the lung cancer report, where you will see the kind of things that we write about in the lung cancer report, reporting on these genes. You need to be able to understand these so that you can explain to the patient what they mean in terms of treatment. That is the big message today for lung cancer, is understand the pathology report so that you can advise the patient about what treatment they need. All right, let's move right along onto non-cancer lung. All right, I love these little med comic illustrations. So the first thing that we're going to think about is some basic concepts. We're going to think about pleural effusion. So people often are asked about what's the difference between a transudate and an exudate, and they get a bit confused. So what is a transudate? A transudate is due to hydrostatic pressure. So it's due to fluid being pushed out. Okay. So in the lung, a pleural effusion due to congestive heart failure, right heart failure, will be a transudate, and it is low in protein. Okay. And then an exudate, right, occurs due to inflammation. So what happens in inflammation? The little endothelial cells spread apart. Yeah, here they are spreading apart, and it leaks everything out. So an exudate will be high in protein, and will be the typical thing you would see in pneumonia or cancer or a viral infection. So exudate is inflammation, transudate is increased osmotic pressure. Which brings us to pulmonary edema. It's been a while since you've covered that, so we're going to do some pulmonary edema thinking. So what is pulmonary edema? It's a hemodynamic edema because due to its increased hydrostatic pressure, due to increased pulmonary venous pressure, usually because you get left heart failure, and then you get increased pressure in the lungs, right? So left heart failure, increased pressure in pulmonary veins, then you get transudate out into the alveolar spaces, leading to pulmonary edema, which raises the pressure and leads to right heart failure. Okay. But there are some other kinds of pulmonary edema. Okay. So the first kind of pathogenesis of pulmonary edema is hydrostatic. It's the most important. It's due to heart failure. But then there are some things that give rise to direct injury, like infections, right? Inhaled gases, aspiration of gastric contents, radiation lung trauma. Now, these are inflammatory, so they are going to pull apart the endothelial cells. So here you're going to get a high protein exudate. So it's going to have fibrin and all kinds of stuff in it. Okay, it's not just fluid, it's got lots of protein in it too. So let's have a think here about what in this kind of injury, will this lead to an exudate or will it lead to a transudate? So we've got systemic inflammatory response, maybe if there's a bad blood transfusion reaction, etc. All these are inflammatory. So it leads to a proteinaceous exudate. So when there's injury with a proteinaceous exudate, you get the clinical syndrome of acute respiratory distress syndrome because the protein starts to line the little alveoli and doesn't go away quickly like transudative heart failure related pulmonary edema. Okay, that can be cleared up by some physiological intervention like furosemide but yeah, so this stuff sticks around and continues to make the lungs bad. It also makes them very stiff because you get lots of protein lining the alveolar walls, and so they become hard to inflate. So what's the relationship between this, diffuse alveolar damage, and ARDS? Let's carry on. So ARDS is a clinical syndrome, and if you look down the microscope in a person with the clinical syndrome, you will see the changes of diffuse alveolar damage. What do we see? We see a whiteout on the X-ray. They can't breathe, okay, at all, even with high pressure. So the body's response is to have a high heart rate, fast breathing, retractions with the fast breathing, and also they have a low oxygen in the blood despite having a high oxygen and pressure in their ventilation. Okay. The patient does not get better even with high oxygen. Okay. We will understand this when we see the histology. Those of you who like flow diagrams, here's one explaining it all. We're just going to, you can stop the video and take that in and note it down, but we've been through it in a list, so we're not going to through it again. Okay, so now we have diffuse alveolar damage. It's the histology that occurs when there's adult respiratory distress syndrome. And the primary underlying cause is damage to the alveolar papillary endothelium. Remember, it's damaged, so it pulls apart and lets all that fibrin-laden fluid through. And also the alveolar epithelium is damaged. And it gives rise to these red, wet, heavy lungs macroscopically. And microscopically, the fibrin condenses and lines the alveolar space. In addition, this is an inflammatory condition, so we get lots of inflammation in the wall of the alveoli. And now you can see the oxygen exchange is going to be poor no matter what we do, because the alveolar wall is thick and wet and full of inflammatory cells and lined by this thick barrier of fibrin. So this fibrin is called a hyaline membrane, and this is a key word that you need to remember: diffuse alveolar damage and hyaline membranes. So the type 2 alveolar cells, the kind of macrophages of the lung, then proliferate and try and chomp it up. And it heals by myofibroblast proliferation and then fibrosis, which is bad because we need our alveoli to be thin and delicate. And if the walls are expanded by fibrosis, then the patient does not ever get better. They will always be left with lung compromise. Let's have a look at a flow diagram about this. Okay, so there's a damaging stimulus to the lung, like shock or toxic drugs or a bed transfusion, and it does two things. It damages the alveolar lining cells, and it damages the alveolar capillary epithelium, which leads to interstitial edema and the exudate. Now, this is so bad that there is death in the acute phase in 70%. These people are in ICU, desperately being ventilated, given oxygen to try and save them. About 70% die. Okay. Then the type 2 alveolar cells regenerate, and they're the macrophages. Yeah. There is continuing inflammation in the interstitium. So the macrophages can release cytokines that recruit fibroblasts and myofibroblasts, as does the inflammation, which leads to interstitial fibrosis. Now, if it's mild, there will be recovery with minimal residual respiratory dysfunction. And this is many COVID patients who've been in ICU. They come out and they have mild residual respiratory dysfunction. Or it can lead to marked interstitial fibrosis, which leads to death due to chronic severe respiratory impairment. Okay, so that is the pathophysiology and pathway of DAD, and this is the histology. Important things to know. We're going to change topic here. We're going to move on to asthma. Now, you've done a lot on asthma already, but I am going to briefly review it. So asthma, okay. It is more complicated than it used to be because we've discovered a whole lot more about the immune system. So what is asthma? Well, the first thing we need is we'll do the lips. Those of you who've been to my shoots will understand lips. So we're going to think about the landscape. So asthma occurs in people who have environmental triggers and also an inherited tendency towards lung hyperreactivity. So we have antigens that they encounter, okay, which trigger mast cells to produce a whole lot of cytokines and release histamines. So they can get a very acute response, a histamine response, where the airway just closes up. But mostly asthma comes on over a little while, like an hour, and that's due to the release of cytokines, which attract eosinophils, which also release eosinophil proteins, okay, and macrophages, which release TNF-alpha. So in simple terms, the antigens go into activate mast cells, which activate macrophages and eosinophils. So what happens then? Well, what happens then is you get bronchospasm. You get airway damage and inflammation. And that's the acute phase, and that can be resolved by taking the beta antagonists, which cause airway relaxation. But what we really want to do is damp down the inflammation long term, which is the role of the steroid inhaler. Okay, then if you get lots of asthma for a long time, what happens is you get remodeling of the airway, where you get an increased number of smooth muscle cells, so like it's ready to go more effectively to contract and cause asthma. And you also get increased mucus cells, which can lead to things like mucus problems. Okay. So if you like lists, here we go. Airway inflammation and bronchial hyperresponsiveness, right, can lead to bronchoconstriction, bronchial wall edema, and excess mucus secretion with epithelial shedding. This is the acute response, and then chronically there's airway remodeling. So this becomes this. We've got increased smooth muscle, we've got increased mucus cells, and overall the airway is narrow. All right, this is another diagram about bronchospasm showing that it is related to the smooth muscle, but also there's a bunch of edema going on as well. And this is yet another summary. I think we've got the idea by now. So what is COPD? Chronic obstructive pulmonary disease. Well, it's kind of three conditions: emphysema, chronic bronchitis, and non-reversible asthma. And altogether, they're adult disease, often an older adult disease known as COPD. And they progress. Okay, so the initiation can be many things: smoking, chronic infection, chronic reactive airways, can lead to chronic obstructive pulmonary disease that narrow the airways and make it difficult to breathe. Let's think of this. So emphysema, irreversible enlargement of the airways. There's several ways to classify emphysema, but often it's done using an anatomic classification where we think about where the thing is dilated. Okay, it can be dilated at the end. This is the most commonplace, pan-acinar emphysema, or it can be dilated further up the respiratory tree, centri-acinar emphysema. I actually find this a particularly useless classification because people don't present with this. They present with symptoms due to causes, and I prefer to think of it in a pathophysiologic way rather than an anatomic way. So here we go. So let's think about alpha-1 antitrypsin deficiency, all right? Because this is the primary cause of emphysema that happens in young middle-aged adults. So alpha-1 antitrypsin deficiency is due to a deficiency in antitrypsin, the antiprotease. So what does trypsin do? It damages, it breaks down protein. Okay, so in particular, it breaks down trypsin. Trypsin normally kind of eats the elastin in the lungs, so this antitrypsin will stop the lungs self-damaging through inflammation. So alpha-1 antitrypsin is the brake on trypsin, and therefore it's the brake on lung degradation. So if it's absent, you get elastic tissue damage, and therefore emphysema. If people smoke, then this also decreases the alpha-1 antitrypsin. So if people smoke and have alpha-1 antitrypsin, they get serious emphysema below the age of 40. So if they don't have alpha-1 antitrypsin and they smoke, okay, they get some decreased protease, but they also get increased protease because it activates the neutrophils and macrophages. So let's have a think about this. It's a bit like a seesaw, right? So normally we're like this. Alpha-1 antitrypsin means that disease means that the trypsin levels increase and are more active. And if you smoke as well, then that happens even more because you get increased protease. How does it do this? How does it do this? All right. So it does this through reactive oxygen species smoking. So smoking causes reactive oxygen species. This is things like single oxygen molecules to decrease the antiprotease and increase the protease. And then neutrophils, which are full of damaging materials, then become activated, causing elastic damage, and cytokines recruit more inflammation. Okay, so let's have a look, think about this again as a big picture. There's two other things we need to think about. There's alpha-1 antitrypsin and smoking. Yeah, there's reactive oxygen species, which recruit neutrophils and cytokines. But where do these come from? They come from the blood vessel. So, and the cytokines come from macrophages. So in the big picture, we can say both alpha-1 antitrypsin deficiency and smoking decrease antitrypsin, antiprotease. Smoking does this through reactive oxygen species, whereas alpha-1 antitrypsin does this through a deficiency that's genetic. The reactive oxygen species recruit neutrophils from blood vessels. They also recruit cytokines from macrophages. All these things, give rise to an increase in protease, which further damages the elastic in the lung, leading to emphysema. It's very complicated. If you're at the live lecture, I'll spend time answering questions until you've got it in your head. All right, let's move on very briefly to chronic bronchitis, bronchiolitis, and bronchiectasis. So what's the difference between these? So chronic bronchitis is a chronic disease where you have smooth muscle hypertrophy and you have fibrosis in the wall of the bronchi along with increased mucus. And that's due to goblet cells and increased bronchial glands. So chronic bronchitis does look a bit like chronic asthma, but it doesn't quite have the same histamine mechanism acute phase. What it does have is thick, sticky mucus and a thick wall that has made the airspace narrow. Okay, so this is why people cough up a lot of mucus. The mucus isn't easily cleared and gets infected. So this affects the bronchi. All right, so what's bronchiolitis? So it affects the bronchioles, so further down the tree, right? Chronic, so similarly in bronchiolitis, you get inflammation with goblet cell hyperplasia and mucus secretion. It can be an acute reaction, so you don't get the smooth muscle hyperplasia, but you can get fibrosis if it starts and isn't resolved properly, which is why people can get multiple attacks of bronchiolitis and will be left with some chronic breathing problems. All right, so difference between chronic bronchitis and bronchiolitis is in the smooth muscle and in the size of the airway. Bronchiectasis is where you get abnormal dilations of the airways. So these will become smaller and this becomes bigger, either cylindrical, what's called varicose, or cystic, and they fill up with mucus. And the mucus gets infected, and then the infection in the wall damages the wall more, which means they get more dilated. So this is what is the vicious cycle of bronchiectasis. Okay, so let's have a look at that again. So if this bronchiectasis, for example, is typical in cystic fibrosis, but it can happen in any disease that causes obstruction of the airways. Like cystic fibrosis, it's mucus plugs, but it could be anything. So we have impaired mucociliary clearance, retention of airway secretions because it's blocked, which leads to chronic infections. If people have an additional immune deficiency, that can also lead to chronic infections. Both these things lead to airway destruction. And in this case, with the airway remodeling, it leads to bronchial dilation. And then they fill up with more mucus because it can't clear. And we start it again. So bronchiectasis is a self-reinforcing cycle. All right, this is a shocking statistic. 50% of bronchiectasis in children is missed. It is 11 times higher for a Pacific child and 4 times higher for a Maori child than for a New Zealand European child. So if you have a child that has wheeze, crackles, and or recurrent pneumonia, please request these investigations. Sputum sample, X-ray for blood count and CRP, immunoglobulins to see if they're raised, not to see if they have plasmacytoma, and you need to test for TB as well. Okay, this brings us to the end of the first half of our lung lesson. And next time we're going to talk about interstitial lung disease. Thank you.